This lesson is about ventricular rhythms. In a normal heart, the SA node is the primary pacemaker of the heart, producing sinus rhythm, and it depolarizes the heart between 60 to 100 beats per minute. And we've learned that if the SA node can't pace the heart, the AV node can pace the heart at a rate of 40 to 60 beats per minute, and that's called junctional rhythm. Now, if the SA node and the AV node can't pace the heart, the bundle branches can pace the heart from within the ventricles. And that happens at a rate normally of 20 to 40 beats per minute. And we call that idioventricular rhythm. Idioventricular rhythm, or also called IVR, it has a regular R-R interval, just like sinus and junctional. However, it has no associated P waves whatsoever. And that's because this rhythm comes from within the ventricles. It does not originate in the atria, so there's no atrial depolarization, and so there's no P waves. IVR has a wide QRS complex. And what you see is in sinus rhythm that electrical impulse travels down through the bundle branches simultaneously, depolarizing both sides rapidly and evenly. And that produces a narrow QRS complex. However, in idioventricular rhythm, that rhythm originates from within the ventricles. And so it has to depolarize one side and then the other side, and so it produces a much wider QRS complex. So if you were in sinus rhythm and your SA node stopped functioning, what you would expect, assuming the AV node didn't pace the heart, you would expect that the ventricles would hopefully pace the heart. And what you're going to see is a really wide and bizarre QRS complex. And we would call this a ventricular escape beat. You can see there's no P wave in front of it. It's noticeably wider than their normal QRS complexes. And if the SA node and the AV node didn't pace the heart for an extended period of time, you would expect the patient hopefully would be in idioventricular rhythm, which would just be slow and wide and bizarre. Now, idioventricular rhythm has a couple of drawbacks. Now, yes, it's better than asystole. However, it's pacing at a much slower rate of 20 to 40 beats per minute. And with ventricular rhythms, there is no AV synchrony. So there's no atrial contraction prior to the ventricular contraction. And if you remember what we discussed before, atrial contraction forces blood down into the lower chambers, into the ventricles. So when the ventricles contract, then you get the most cardiac output that you can. However, with idioventricular rhythm, there is no AV synchrony, and the heart rate is very slow. And the ventricles are also, they're not contracting simultaneously, your left or your right. They're contracting very slowly, one and the other. So overall, it's a very reduced cardiac output in idioventricular rhythm. Here's an example strip of IVR. So you can see there's no P waves anywhere. The QRS is inverted, and it's very wide. The T wave is still upright. And that's what you see in a lot of these in ventricular rhythms, is you see the QRS is often inverted by comparison to the T wave. So you may have an inverted QRS and an upright T wave, or you may have an upright QRS and an inverted T wave. Often those two are reversed. Also, the heart rate on this strip, well, it says 42 beats per minute. However, You have to look closely at these strips to make sure that it's telling you the right heart rate, because here you can see that N means it thinks this is a normal beat. And this little V says that this computer software thinks that this T wave, it thinks that's a ventricular beat. So it's actually doubling the heart rate. When it says 42, that's incorrect. It's actually half of that. So their heart rate is actually 21 beats per minute. Accelerated idioventricular rhythm is just faster. So it's 40 to 100 beats per minute. Just like IVR, R to R is expected to be regular, no associated P waves, and of course a wide QRS complex. And this is just faster, and you might see this interrupt normal sinus rhythm because it may actually outpace normal sinus rhythm. If your patient their heart rate is normally 60 beats per minute, then what you might see is you might see it actually interrupt their normal sinus rhythm. And then go back to normal sinus again. So just like IVR, but it's just a faster rhythm. Here's an example of idioventricular rhythm. Heart rate's 67 beats per minute. That looks like it's accurate. No P waves that are visible. Inverted QRS, upright T wave. Ventricular tachycardia. This rhythm is a little different. It's still a ventricular rhythm. However, it's a lot faster, so greater than 100 beats per minute. The R to R interval is expected to be regular, no associated P waves, wide QRS. So it sounds just like IVR and AIVR. However, this rhythm is a little different in the mechanism. Instead of one location that is pacing, what you have with ventricular tachycardia, or called VTAC, is a reentry. So it is a reentry, kind of like when we talked about atrial flutter, how in atrial flutter there was a reentry happening in the atria that was depolarizing in kind of a loop over and over again. This is happening in the ventricles now. So if this is your patient and they have an episode of VTAC, they're going to have this really fast wide ventricular rhythm. And this could last a few beats, or it could be sustained. So here we've got 1, 2, 3, 4, 5 beats of ventricular tachycardia. Now, we talked about IVR and how ventricular rhythms have less cardiac output because there's no AV synchrony. Now, when you take that heart rate and you increase it dramatically, then you really get a potential for the patient becoming dizzy or passing out, because we're speeding up that ventricular rate rapidly, and there's not going to be a lot of cardiac output coming out. So some people may be very symptomatic with this and pass out, and others maybe can tolerate it more, but it's still something to take very seriously. Here's some example strips of ventricular tachycardia. You can see up here we've got this early beat, wide QRS, inverted T wave, and there's 1, 2, 3, 4, 5, 6, 7, 8 beats. And how fast is this? So 8 beats of VTAC at how fast? So there's looks like there's about 2 large boxes between R to Rs. So 1, 2, and if we take 300 by 2, we get 150. So 8 beats of VTAC at 150 beats per minute. Now look at the bottom strip. Well, that's much faster. Much faster. So we have, it looks like about maybe a box and a half. Maybe a box and a half between R to Rs. So if we take 300 divided by 1.5, we're looking at about 200 beats per minute. So that's much faster. And that looks sustained. Okay, premature ventricular contractions, or PVCs. PVCs are single beats that come from the ventricles, and they're wide and bizarre, just like all the other complexes we talked about in ventricular rhythms. They have no associated P waves. The T waves are usually inverted. They have what's called a compensatory pause. And a compensatory pause essentially means that since they occur within the ventricles, they don't travel all the way back up and depolarize the SA node and reset the atrial timing. That's not essential to know, but it's just a characteristic of PVCs. PVCs can be uniform or multiform. So a uniform pair of PVCs, you would say they look the same, like that. However, a multiform pair might look like this. So a multiform pair of PVCs would imply that each PVC came from a different location. Whereas the uniform PVCs, you would expect maybe they came from the same location. PVCs can occur in a couplet or a pair, like we just showed you there. They can occur bigeminally. So every other beat would be a PVC. Like that. So every other beat is a PVC. That's bigeminal PVCs, or ventricular bigeminy, you can call it. Trigeminal PVCs would be every third beat, and quadrigeminal PVCs would be every fourth. Interpolated PVCs are when a PVC occurs right between two QRS complexes. So, for example, you'd have, and there's a PVC. Something like that. So the R to Rs are even, and a PVC is sandwiched right in between. That's an interpolated PVC. And then we have R on T PVCs. R on T PVCs are when a PVC occurs and it starts in the middle of the T wave and the beat right before it. So when the R of the PVC is on top of the T of the other beat, that's called an R on T PVC. And we'll discuss that in more detail in a couple of slides from now. Okay, here's on the top is an example of a single PVC. As you can see, it's early, and it's got a very wide QRS complex. And just to mention about the compensatory pause, what that means basically is that it does not disrupt the atrial timing. So here's a P wave, P wave, P wave. There's going to be a P wave hidden right in there somewhere that you can't see, that's unassociated with that complex. And the next P wave falls right on time. So that PVC did not disrupt the atrial timing. And that distinguishes it from a PAC, which would. And a PAC that would alter the pattern of atrial depolarization for the rest of the strip. In the bottom strip, we've got, looks like a pair of uniform PVCs. So each PVC looks exactly the same. Okay, next strip, on the top we have ventricular bigeminy. So every other beat is a PVC, ventricular bigeminy. And something I'd like to point out in this strip is in front of this, so here you see, here's a P wave right in front of this QRS, right? Well, I also, looks like I see a P wave in front of this QRS, but that's a PVC. And we already said that PVCs don't have P waves in front of them. And I just want to point out that this is not associated with that PVC. It just, what happened is that the atria was depolarizing and this ventricular bigeminy occurred. And so before the ventricles had a chance to depolarize from that P wave, this ventricular depolarization occurred. And so it's basically just a fusion. As you can see here, it starts to slowly merge into that complex, and it disappears. And that tells me that it's not associated with that ventricular beat. So you see a P wave that's on time in front of that PVC, and it's not associated with it at all. Just wanted to point that out. Okay, the strip on the bottom looks like we have, well, this is an interpolated PVC because here's the QRSs, they're normally, right, this pattern, and this PVC is sandwiched right in between them, right here. Also, this PVC looks like it's beginning in the middle of the T wave of this beat right about here. So it looks like it's also an R on T PVC. So let's talk about R on T PVCs. R on T PVCs, like we said, we talked about them occurring in the middle or on top of the T wave of the beat occurring before it. Well, I'm going to flash back now just for a minute back to when we first started doing measurements of heart rhythms, and we talked about measuring the patient's QT and also doing a QTC, which is corrected QT for compensating for rate changes. So why do we measure the QT? Well, we measure the QT for this reason. When a patient has during the T wave, there are two phases to this T wave. You have the absolute refractory period, which is here, and you have a relative refractory period, which is here. Now, during the absolute refractory period, no matter how much electrical stimulus is applied, those cells are not ready to depolarize again yet. However, during the relative refractory period of that T wave, they are. You can apply some electrical stimulus and those cells might depolarize. Now, the problem with this is that those cells are very vulnerable. They're in a vulnerable state during that time, and if there is an electrical stimulus within the ventricles that causes them to depolarize, it can cause them to develop into a lethal arrhythmia. So, for example, your patient has an R on T PVC. It can cause torsades, which we'll talk about in a minute, or ventricular fibrillation, which are lethal arrhythmias. Now, we measure the QTC because, well, here we'll say patient A, that's their QT, right? Measure from the beginning of the Q wave to the end of the T. So we'll say patient B, this is their QT. It's patient B. Which one is more susceptible to developing a lethal arrhythmia? Well, patient A, their relative refractory period is this big, and patient B, their relative refractory period is huge. So the longer the QT, the more vulnerable that patient is to developing a lethal arrhythmia. So it's really important to measure that and to see if it's getting longer. Some medications can cause QTs to get longer, or some patients just have long QT syndrome where their QT is just extended, and they're just always vulnerable for these lethal arrhythmias. Torsades. We just talked about torsades. Torsades de points. It's called twisting of the points, and it's a twisting pattern that I described, which looks like something like that. Lethal arrhythmia, shockable, and it can be caused by those RNT PVCs. Here's some example strips. So looks like these are their normal beats here. And it looks like they're having R-on-T PVCs there and there. And then this one caused this torsades to happen. So you can see how it's wider, and then it kind of gets narrower, and then it's wider, and then it's narrower, and then it's wider. So that's that twisting of the points. That's why they call it that. And then down in the bottom strip, that's just the sustained torsades. Ventricular fibrillation. This can also be caused by RNT PVCs, and it's a lethal arrhythmia. And ventricular fibrillation can be very coarse, like that, or sometimes it can present itself and be very fluid, like that. But essentially, your heart rate is 0, and this is also a very lethal arrhythmia, and it's very shockable. So if the patient has an ICD implanted, it would expect a fire, or if you found the patient unconscious and you applied an external defibrillator to them, it would advise shock. And here's an example of ventricular fibrillation. This is very coarse. This one starts with another R-on-T PVC. And that concludes ventricular rhythms.